Well, I said good morning. I know for some of you, it's good afternoon or even good evening, because as I look at our list of registrants of over 500, I see that we have people here from all across the United States, as well as three continents, with Australia, I think, being the furthest away. But wherever you are, whatever time it is, we are delighted that you could join us. So welcome. Welcome to the 32nd Annual Lead Conference here at Montefiore Medical Center in New York. We are delighted that you could join us for. My name is Nancy Redke, and I'm the field coordinator here at the lead program. As usual at this conference, you will all be muted throughout, but you will have access to the chat and can make comments and ask questions throughout. And I promise you, we will try to get to as many questions as time will allow. But in the meantime, we thought you might be interested in knowing a little bit about your fellow attendees. So we are going to post a question on your screen. And when you see it, you'll see there are several answers that you can choose from. All you need to do is click on the circle next to the answer that applies to you. And I assure you that all of these answers are anonymous. You're simply going to see the results as an aggregate percentage. So if our audiovisual people will post that question now. You can see what your choices are as they come in, and all you need to do is hit submit after you've made your choice. So while the results are coming in, I know that some of you are here as first timers, and we're always delighted to have new people joining the field. And at the other end, I know there are some who have been here in this field laboring for over 25 years. And we know that it's on your shoulders that we stand and depend on for your expertise and your experience. And I hope that whichever end of the spectrum you're on, that you will all find that there's something for everyone in today's program. So while the results are coming in, I'd like to just say a word about the photo you saw. Some of you have actually been around long enough that you know about Dr. Rosen, and you know that Dr. Rosen is a world-renowned pioneer in the lead field. He was not only a pioneer, but a pediatrician, researcher, and advocate, and just an all-around champion for children with lead poisoning. And it was here at Montefiore that he began his international career way back in 1969. And from the start, he felt that it was absolutely essential that we use a multidisciplinary approach if we were going to really tackle lead poisoning prevention and treatment. And so he began bringing together a team of professionals in medicine, in research, in social services, and environmental investigation, as well as in public advocacy. And it was this team that through the years has been running our program and our weekly clinic all the time, supported by our in-house laboratory. Another part of his vision was that we have a lead-safe house where families whose homes are being remediated would have a safe place to stay during the dangerous time of that work. And so today we have a 6-apartment safe house where these families can stay. Obviously, over the years, we've built on that vision of Dr. Rosen's. And so I'm particularly pleased to be able to introduce to you today a longtime colleague and of Dr. Rosen's and our current director of our program, Dr. Maury Markowitz. Dr. Markowitz received his MD at the Albert Einstein College of Medicine, and since 1978, he has been a professor of pediatrics there, as well as an attending physician at our children's hospital. On the national level, Dr. Markowitz served 6 years on our CDC lead advisory panel. This was the panel that developed the guidelines for evaluation and management of lead exposure during pregnancy and lactation. And he has served on similar panels at the state and local level. All told, Dr. Markowitz has 40 years of experience as a clinician, a scientist, and an educator, focused most of the time on lead poisoning. He is also an active researcher and was funded by our National Institutes of Health for over 20 years. So at this point, I'm going to turn the program over to Dr. Markowitz, who will introduce our first speaker. Dr. Markowitz.
Thanks, Nancy. Thanks for the introduction and the bio. I think I would update the bio to say that it's now about 50 years instead of 40 that I've been taking care of lead-poisoned kids. And it's been a remarkable time to have had a career in this field, because we've really had a major public health success. When I started, the hospital wards were full of severely lead-poisoned kids. Lead mortality was still happening in kids in the United States. And that's, I hope, a thing of the past here. That's not true in the rest of the world, where apparently there are not only kids, but especially adults, usually from occupational exposures, that are still dying from severe lead poisoning. So it's a public health story success from that perspective, that it's not a killer, but it still has effects on the brains of kids primarily, and multi-organ system dysfunction as you move up into the adult world with exposure and absorption of lead. So the reason for that is that we still have an enormous amount of lead that we've spread on the surface of the planet. And I think that's going to be true for many generations to come. We've reduced it in terms of how much new lead we put in, but there's still a lot there. And having lead in the environment is only the first step, because it has to find a pathway into your body. And for kids, that's by ingesting it, overwhelmingly the path. And how much of that lead that is ingested is absorbed and retained is in part dependent on the nutritional status of the child. If you're missing essential nutrients, especially the essential metals, you may absorb more lead, you'll retain it longer, and the combination of too much lead and too little of what you need is more toxic. And finally, it's harder to get rid of the lead from your body by yourself. And that was really a part of the way that we moved towards developing drugs that would help us to excrete lead at a faster rate, and thereby reduce mortality, first of all, and hopefully reduce toxicity as well. The problem there is that we only have drugs that are effective at very high levels of lead as we assess it in people, and our gold standard remains the blood lead level. So with that as our introduction and covering why we're having a conference that is focused on interventions, I'm going to introduce the first speaker. So Andrew Fasciano is the Assistant Commissioner for the Bureau of Environmental Disease Prevention within the New York City Department of Health and Mental Hygiene. In this role, Andrew oversees the Healthy Homes Program, New York City Poison Control Center, Office of Environmental Investigation, and environmental exposure assessments and education. These programs aim to prevent environmental disease and injury in homes, communities, and the workplace. Most of Andrew's career has been focused on reducing childhood lead exposure. As the executive director of the Healthy Homes Program, he is part of a team that has implemented a broad set of policies to further reduce and prevent lead exposure, including lowering the blood lead level threshold for intervention to 3.5 micrograms per deciliter, and establishing lead in dust and lead in paint standards that are lower than current federal guidelines. There's no one better suited to give this talk on how to reduce and eliminate childhood lead exposure. Andrew, you're on.
Thank you, Dr. Markowitz. Good morning, everyone. I want to start by acknowledging the leadership and advocacy of Monty's lead program. You've been a leader in this space, obviously, like you said, for decades. And your program is such an incredible resource for New York City children, but also for local health departments. So with that, I'd like to pull up the poll, the first poll. I'll give you a hint to the answer, but once I see that, we can start. So for background, there are about 230,000 children less than 6 years of age are tested in New York City. So with that, try to see if you can guess the number of children who had a blood level of 3.5 or greater in 2024. I'll give you a few seconds. And while you're reviewing that, just a little bit of just a disclaimer about my presentation. I'm going to be comparing and contrasting different lead exposure sources, but by no means am I trying to minimize any of them. All are important and all can contribute to a child's blood level. So I just want to throw that out there, that we're giving New York City's perspective, which may not match perspectives or exposure sources throughout either your jurisdiction or your country. So I think the poll is done. If so, then I will share my slides and we will go from there. Okay, just let me minimize. Okay, I'm just trying to drag the bar. Here we go. Okay, great. So in terms of the overview of my presentation, I will give you a brief history of New York City's fight to address childhood lead exposure. We've been unfortunately doing it for many decades, and the fight continues. And then I'll give you some background on how we conduct investigations in the homes of children with elevated blood lead levels, and talk about the results of those investigations in terms of the typical exposure sources found, and not only talk about the ways we address them, but also some other approaches that you can address depending on your jurisdictional resources and authority. And finally, I'll close this presentation on my opinion on what matters the most, with also the caveat that everything is important too. So hold on one second, just minimizing this. So New York City, as Maury mentioned and Nancy mentioned, has been a leader in the fight against childhood lead exposure. The alarms really started sounding here in New York City in the early 1940s, based in part findings promoted by the health department at the time. And it really came to the center of public consciousness in 1955, based on a Daily News article in some respect, that highlighted the unfortunate deaths due to lead poisoning of 10 children in Brooklyn. That public outcry led to New York City becoming one of the first jurisdictions to ban the interior use of lead-based paint. And then about 10 years later, 1 year after the Monty program was established, that New York City established the Health Department's Bureau of Lead Poisoning, which is now called the Healthy Homes Program. Excuse me. And that year, there are over 2,600 children with blood levels of 60 micrograms per deciliter or greater, which would today be considered a medical emergency. I'm happy to report that in 2024, there were only 4 children who tested with a blood level of 60 micrograms per deciliter or greater, which is part of a public health success story. So in terms of lead-based paints, history of usage in New York City, while we did ban lead-based paint in 1960, we had many years where lead-based paint was applied, and New York City is an old city. So fast forward today, more than 50% of all housing in New York City is built before 1950, and the median age of housing throughout New York City is 1958. We have seen lowering of the allowable amounts of lead in paint over time. Prior to any limits, lead-based paint could have been comprised of over 50% lead, which is 500,000 parts per million, incredible high concentrations. Back in 1960, New York City lowered it to 600 parts per million, followed by the federal government following suit. And then for a good 18-year period, I mean, actually, no, more than that. It's until 2009, lead in paint could contain up to 90 parts per million of lead. So it shows that not only do maybe some of the oldest housing has background, the first couple of layers being lead-based paint, but even more recent layers of paint could have levels up to 600 parts per million of lead. So it's important to recognize that those levels can also contribute to a child's blood lead level. So we have had a tremendous success in reducing the incidence of childhood lead exposure as well as the prevalence. This chart looks at trends over time for children with blood lead levels less 3.5 micrograms per deciliter or greater, and you'll see tremendous declines, but more recent last 5 years, a slowing of decline. So the point where it's the rate of decline has really diminished. So this points to the fact that more work needs to be done and more exposure sources need to be addressed. And we had over 4,600 children identified in 2024. This next chart looks at blood levels of 5 micrograms per deciliter, slightly higher, and what's being used as a threshold in a lot of other jurisdictions throughout the United States. And you'll see similar rates of decline and also similarly a slowing of the rate in the last 5 years. And so in 2024, we had about 2,600 children with blood levels of 5 or greater. So this shows that while tremendous progress has been made, a lot of work has to be done. It's unacceptable that 2,600 children have blood levels of 5 micrograms per deciliter or greater. So what is some of the reasons why we've had tremendous success? A lot of the success here in New York City can be attributed to strong primary prevention laws, which in part were passed due to advocacy within concerned citizens within New York City. We have here in New York City a coalition to end childhood lead poisoning, and that group really were leaders in getting many different aspects of these laws passed, and they also continue to advocate for approaches to reduce and eliminate childhood lead exposure. But the backbone of all of our primary prevention is Local Law 1 of 2004, which is enforced by our housing department, the people who do code inspections. This law requires that building owners inspect and safely repair lead paint hazards in homes of young children on an annual basis in the hopes of preventing exposure. It also allows tenants throughout New York City to call the city and ask for a lead paint inspection. And HPD will go out and do a lead paint inspection. And in the HPD inspectors are also checking for peeling paint as part of their other inspections. If they're going for heat or hot water or other code inspections, they are checking for peeling paint. So they're identifying opportunities to find potential lead-based paint hazards and ordering building owners to correct those hazards. And Local Law 1 also created a rule that any new childcare would have to show evidence of being lead-free, with other rules for childcare that were in existence that they must annually assess for deteriorated paint and make corrections if they find deteriorated paint. So our health department is supported in primary prevention through both a New York State public health law, which requires the testing of children at age 1 and again at age 2, regardless of risk. So it's a universal blood lead testing requirement. And it also requires healthcare providers to assess children at each well visit up to the age of 6 years and test those children when deemed at risk. All of the blood lead test report results are reportable to the department, and that has allowed us to create a very robust childhood blood lead registry that contains 30 years of testing results for over 6 million New York City children with 10 million blood lead test results. And it allows us to provide data on trends over time. It allows us to identify neighborhoods where we see disproportionate rates of lead exposure, and it is the basis for everything we do. So it's important that if you're going to address lead exposure, you have to have a way to measure and get reports from the children in your community. New York City Health Code gives us the authority to investigate And so our current level is 3.5. It also gives us the authority to investigate complaints of unsafe work. This is basically construction practices that may be disturbing lead-based paint and contaminating buildings. Gives us the authority to investigate and embargo consumer products that are contaminated with lead. And it sets all the different environmental thresholds we need to do enforcement. And finally, it creates these standards for what's considered lead safe work practices, including the prohibition on dry sanding and scraping. So we've had local law 2000, local law 1 of 2004 was the backbone of everything, but there's been a lot of recent legislation that is aiming to further advance primary prevention of childhood lead exposure. I'll just go over a few of these. One of the more important ones was Local Law 31 of 2020, which required all building owners with rental units to test every apartment for the presence of lead-based paint. And this is test all surfaces. So it really required building owners to get a better sense of whether or not their rental units have a lead issue. And it gives them the information so that they can either make a decision to replace items, aka abate items, or to ensure that surfaces that have lead-based paint are maintained and in good condition. Another important law that was passed recently was a requirement that owners use this testing information to permanently abate, aka permanently remove, friction surfaces on doors and windows in all child-occupied units by January 2028. That work is some units are already it applies to, but and ultimately endpoint for all different units is by January 2028. So this is going to go a long way in removing some of the most high-risk surfaces in New York City. So one additional requirement that was born to city agencies was that in an effort to be more proactive and use data to focus resources, there was a law that was passed that the health department would work with HPD to identify buildings that were at greater risk of lead exposure so that HPD can go in and proactively audit building owner compliance with all of the host of different laws that are aimed to prevent childhood lead exposure. So I'll now dive into how we conduct investigations. And for other local health departments here in the state on the call, this is very familiar. It's a similar approach, but ultimately, when we get those blood lead test reports, the ones that we consider elevated, we are assigned to a public health nurse. And that nurse is tasked with having that initial conversation with the family, helping them understand what your child's blood level means, what's going to happen, what steps they can take, and what the process is going to happen in terms of working together to try to find the sources of potential exposure for their child. So because we're the first people contacting families, and because we'll have continued conversations with families, we become trusted advisors. And that trust allows us to get information that helps to form a understanding of risk factors and potential exposure sources that may be contributing to that child's current blood level. And nurses are not only having that initial conversation, they're staying with the family and supporting the family until the child's blood level declines to what would be considered a non-action level. They'll also work closely with the healthcare providers to monitor blood level trends. They're also helpful in identifying potentially new or previously unexplored exposure sources, and they're working to facilitate referrals, including with Monty's team, if there's a need for lead-safe housing. So our nurses work hand in hand with our public health sanitarians, also known as inspectors, to work as a team to try to get a better understanding of what's driving this child's blood level. And our sanitarians will take over the environmental investigation component, where they're going to start with a visit to their child's primary residence. And at that point, they're going to sit down with the family, conduct an in-depth risk assessment that will not only identify potential exposure sources in the home, but where other potential exposure sources, including where children may spend at least 5 hours per week. And those places are then evaluated as well by the health department. So this risk assessment questionnaire is a vital component of this investigation because it helps inform the need for additional sampling of other exposure sources. So, and we'll talk about some of those other exposure sources soon, but it's really important that that as part of the investigation, you're probing and asking questions not only about risk factors, but potential exposure sources. So you really have to have a good understanding of all the different places a child can get exposed. In addition to doing some sampling in the home, we will send drinking water testing kits to measure lead concentrations of drinking waters. Families are directed to take the first draw of the day. Typically, when the water is stagnating overnight, this can lead to maybe showing that if it's an internal plumbing issue, if there is lead in the drinking water. And when we do identify lead hazards, and if the lead hazards are either lead-based paint or lead dust, lead in soil, we will direct the building owner to abate that hazard. Abate means permanently remove. And in doing so, they also have to do that abatement in a manner that does not contaminate the property. So they have to do it in a lead-safe manner, and they need to show evidence of this by submitting lead dust clearance samples that show that the residual dust is below regulatory limits. And so here in New York City, if the owner doesn't do the work, New York City has contractors on call that will go in and do the work and build the building owner. And I understand that may not be a resource available to other jurisdictions. So like most other health departments, the way we measure lead in paint is through a portable X-ray fluorescence device. We'll call it X-ray from here on out. It is a very convenient device that is able to detect lead through multiple layers of the surface coating, so that you're not only testing the surface layer, but you're testing the embedded lead. And it's very good because it's very good at making a quick determination on whether that surface you're testing meets the definition of lead-based paint. Here in New York City, we treat an XRF measurement at or above 5 milligrams per centimeter squared as lead-based paint, and we order the abatement of that surface if it is. Whereas in US and other jurisdictions, most of them currently use a threshold of 1.0. So we lowered it to 0.5 because it was a way to be able to order the removal of a component at lower levels and hopefully remove more lead from the environment as a result. So there are other ways to detect lead in painted surfaces. One of them is paint chip sampling, which can be very precise, and it can help determine lead concentrations when you can't use an XRF device or it's not appropriate to use an XRF device. I will caution that paint chip sampling is expensive, time-intensive, and destructive. And if you don't do it right, you don't take down to the bare substrate, or if you include substrate, you may yield erroneous results. So it is a very specialized thing to do paint chip sampling, and as a result, we don't generally perform paint chip sampling as a way to determine the presence of lead-based paint. There are other approaches that may be useful to families and consumers if they really just wanted to get a sense of a product they're using, or the paint that they have in their house may have some lead in it. But there aren't many. There are only a few, and they're more qualitative. They're not going to tell you the concentrations. There is a promising, relatively new approach, perovskite-based photoluminescent detection. It's basically you take a solution, you spray it onto you score a surface, scratch a surface, you spray it, and then you shine a black light on that surface, and it illuminates if there's lead there, and the magnitude of the illumination can be correlated with the concentration of lead. Again, it doesn't tell you the number, but it just gives you a sense on whether or not a product may have lead in it, and maybe if further investigation is warranted. So The approaches to address lead-based paint can often be informed by financial resources and regulatory authority. Removal of all lead-based paint, even if the surface doesn't pose a hazard, would be a great practice if it's possible. But it is extremely expensive to do, and not all jurisdictions have the resources to require that, nor do they may not have the authority to require that. So absent that, the resources and authority, that abating surfaces that are deteriorated is the next best thing, including friction surfaces, impact surfaces, anything that is the removal of surfaces that are more likely to be deteriorated would be the next best approach. Encapsulation, which is the application of a thick paint that binds to lower levels, lower layers of paints, can be effective, but it really depends on the condition of the substrate it's being applied to and whether or not that ongoing maintenance of the encapsulated area is occurring. And finally, interim controls, which basically bringing the paint to an intact condition, can help prevent short-term exposure at crucial points in a child's life. So there are windows where risk is greatest for childhood exposures, and if resources are limited, sometimes interim controls can prevent, on a short-term basis, prevent exposure. So lead-contaminated dust, I'll preface that lead-contaminated dust can have many different points of source points. For the purposes of this presentation, most of the time here in New York City, lead-contaminated dust is highly correlated with lead-based paint, but that doesn't mean that's going to be the case in your jurisdiction. It could be related to industry. It could be related to hobbies, work. For example, gun ranges, if you go into a gun range, the lead contaminated dust in a gun range is probably from the firing of bullets. So it really depends on your local jurisdiction on what's the source of the lead contamination that's being found in the dust. But for the purpose here in New York City, we generally assume that if you're finding lead contaminated dust in the home of a child, the best approach to address that is to get rid of the lead-based paint. Absent the ability to remove the lead-based paint, then you can use wet cleaning methods coupled with HEPA filtered vacuuming to reduce dust lead levels. But without addressing the source, those levels may start creeping up again. And as I previously mentioned, if you're going to disturb lead-based paint, you need to do clearance dust wipe sampling. And even if you're cleaning lead-contaminated dust, you should perform clearance dust wipe sampling to ensure that the cleaning was done properly. So lead in soil, lead does naturally occur in soils, but generally at low levels. But you'll see that urban soils and areas impacted by human activities generally have higher lead levels due to a lot of the industrial practices, including the use of lead in gasoline, lead paint on exterior surfaces, and many houses were painted with lead-based paint. Here in New York City, there have been surveys that have identified lead contamination of soil in various New York City neighborhoods. We have a lot of the focus here in New York City has been to reduce exposure from urban gardening because there are hundreds of shared urban gardens here, in New York City. So the approach has been to recommend the use of raised beds with fresh soil brought from different sources, including here in New York City. We have a fresh soil bank where you can get soil that has been excavated from new development sites. We do a lot of development here in New York City, and they're often taking soil from layers of the earth prior to the industrial age. So that soil is free of industrial contamination, and that's made available for gardeners. It's made available for brownfields projects, a host of different applications. That's a great resource that you can consider for your jurisdiction if the resources allow. And so in terms of our findings, while soil may be a significant source of exposure source, a significant exposure source outside of New York City, we don't generally find many children with EBLs having identified lead in soil hazards. And that could be explains for many reasons. None of them are fully understood. It could be that New York City children, many do not have a backyard, don't get to play in a backyard, or they don't have access. We don't have a lot of painted houses anymore. Most of our houses are brick, or that you just no longer have lead-based paint. And there has been evidence of urban environments having accelerated soil erosion. And it's one of the few times soil erosion could be good. So basically washing the lead away, because this is an urban environment with a lot of cement. So lead in drinking water seems to get the most attention out of all potential exposure sources. And that is rightfully so, due to a lot of missteps by municipal water systems that have led to the increases in lead in drinking water levels. That has dominated the headlines over the years, but it also has resulted in significant funding allocations to address lead in drinking water in both homes and schools. EPA recently lowered the action level for lead in drinking water to 10 parts per billion. New York State requires schools and schools to have levels less than 5 parts per billion. These levels are more of a way to measure corrosion control, not necessarily health-based, with EPA not setting a health-based standard for lead in drinking water. So the biggest contributor, so for the most part, lead levels in water are low, absent environmental contamination. Lead, the water that's delivered to New York City from the upstate reservoirs is virtually lead-free, but lead gets introduced into the drinking water when it touches internal plumbing systems. And the biggest contributor to lead contamination of drinking water here and most other jurisdictions in the United States is lead service lines. That's the pipe that connects your home to the main. And because these pipes can be made almost over 100% lead, and they could be many feet long, there's an opportunity to have the water touch these pipes and sit in these pipes for a long time. So replacement of lead service lines is the most effective way to reduce and prevent exposure of lead contaminated drinking water. There are other plumbing materials, including lead solder joining pipes. Some fixtures and faucets may have a portion comprised of lead. Those can, if replacements a possibility, they should be replaced. If not, then a low-cost approach would be flushing the lines during periods of stagnation. Flushing, for the most part, works as long as the water chemistry is being properly managed, and there aren't these very unique situations such as galvanic corrosion. Flushing can be an effective way to get fresh water from the main, which is virtually lead-free, into your building. So that's one of our recommendations to families. But absent full lead service line replacement, public water systems will have to continue to use the approach they use now, which is to monitor and maintain proper water chemistry and adding orthophosphates to coat pipes to prevent corrosion of lead from the pipe into drinking water. And it's costly and difficult to do. So in terms of our experience with lead in drinking water, in terms of sampling for children with EBLs, we've received over 2,400 kits from families who tested their drinking water as part of our EBL investigations, and 98% of these kits were below the EPA action level, and they were far below. So every year, the median concentration was 0 parts per billion. So we're generally not seeing very high levels of lead in drinking water associated with children with elevated blood lead levels. And there are a couple of hypotheses around that. One of them is that the biggest culprit of lead contamination drinking water, lead service lines, are typically found in 1-2 family housing. So not as many children living in 1- and 2 family housing here in New York City. And lead in drinking water levels are variable. It's not a steady state exposure for the most part. They typically decrease once you start moving water through the pipe. So the showers in the morning, running, flushing the toilet, all these things move stagnating water out of your house and start replacing it with lower lead water or lead-free water from the water main. Now I will focus on lead in consumer products. We have decades of experience evaluating lead content in consumer products and raising alarms about lead in consumer products. And this is another significant exposure source, not only for New York City children, but children of the world. This is one area where I think you'll see a lot of shared potential exposure that is not specific to New York City. So as you all know, New York City is a city of immigrants. We have over 3 million immigrants living in New York City. And what we see more and more is United States is becoming a greater percentage of immigrant population. So we have about 27% of the total US population is immigrant population. And we know that from prior research and the results of our investigations is that immigrant communities are at higher risk for lead exposure. And that in part is due to exposures in their birth country. Lead regulations vary based on country of origin. A lot of times they are bringing in a body burden of lead when they come to our country, and that body burden may be impacted by additional contributions from lead hazards, because immigrant populations will not have as much access to well-maintained housing. So they're likely to live with lead-based paint hazards. And they also continue to use some products that have been implicated as being contaminated with lead, even though those products may not be as readily available here in the United States. So this is, so it's a lot of information. So that's why we have a QR code here, but these are all the different types of products we generally assess for, including food, spices, dietary supplements, ceramic ware, other cookware, a host of different products. And so this gives you a snapshot of the allowable levels of lead in these different types of products. What I will tell you that is when the products we find and associate with EBL investigations, the concentrations are often much higher than what you're seeing here. So while these are great guidance levels to aim for, what we're seeing is lead contamination at many orders of magnitude greater than this. And so you can take a quick shot of that QR code if you want to get more information. So it's important, if you're going to really do a good job in trying to identify consumer products that may be contributing to a child's blood level, is to really become familiar with all the different products that have been in the past associated with lead exposure. And there is, it's also important to, in your conversations with family, to talk about how hazardous some of these products are, but also message about how the risk can increase as the more you use these products. So some of the products you'll see, and you'll see through the data that we have, can have 98% lead. They can be even higher concentrations than lead in paint. And so, and it's important to say that the more you use these products, the greater it's going to harm your health to families. And you're also, in terms of your questioning and probing about products, it's great to know about their heritage so that you can ask specific products that you know have been associated with their country of origin. I'll caution that sampling of products can be difficult because families often don't have the products that they report using. They maybe have brought it from their home country. They don't want to they don't want to lose the product to testing. And sometimes it's not feasible to send the product for testing. But when testing is feasible, the approach to testing is really based on the type of product you're assessing. You can use an XRF to test products that are coated with paints or glazes. You can also use some of those qualitative approaches just to be able to warn families that the product has lead. You can also collect most other products you can collect a sample of an aliquot, and you can actually send to approved and qualified laboratory to determine lead in concentrations. Not all labs will handle, will be able to analyze a myriad of different consumer products. So make sure you have, you confirm with the lab that they're able to do the necessary analyses. And once you get the results back, it's important to provide interpretive guidance. So some of them may have some small amount of lead, but maybe below regulatory limits. But it's still important to talk about how even small amounts of lead can impact a child's blood level. So it's you need to have basically contextualize the sample results of family in a manner that they can understand. And in doing so, you can also, if the opportunity presents, suggest alternative products that may not have as high concentrations or have lead. Examples are spice. If spice is a culprit in terms of exposure, you can recommend spices manufactured in the US. Or if it's the use of ceramic, lead contaminated ceramics, you can say that you don't need to throw this out, but you don't use to store food or cook food in, because lead is leaching from that food into from the glaze into the food. So this approach allows families to continue their cultural practices and traditions, but you shouldn't stop there. After you identify a product, there are steps you can take to actually try to prevent additional exposure from other members in your community. And one way we do that is through undercover store surveillance and enforcement. Our staff, using information gathered either through EBL investigations or news media reports, we go out and survey stores. And so we've surveyed over 2,700 stores in New York City since 2010. And of the ones we found to be contaminated with heavy metals, we've embargoed over 40,000 hazardous consumer products. We also now require business owners to complete a training and post warning signs. Not all business owners know the products they're selling are contaminated with lead. So we try to raise awareness so that they know that they're not going to, hopefully prevent them from selling products that are contaminated with lead in the future. And we share these findings, and we'll talk more about that. Share your findings with both federal agencies and foreign authorities. If you can determine the country of origin for that product, then you should share those findings with that country, because you're not only helping to prevent exposure for the children in your jurisdiction, you're helping the children in those countries and the other impacted populations and adults in that country. So, and you should make your consumer product surveillance data available so that other people can leverage that information to take action. So we use our surveillance data to come up with risk communication messaging and public education. Here are some examples. We develop health warning signs that are specific to products, giving product names, showing pictures, giving guidance on what to do, how to reduce exposure. We come up with, we push out health advisories to engage the healthcare provider community to raise awareness that these products may be impacting the population they serve. We try to engage the press by doing press release to get the word out so that not only in New York City, but other news outlets may pick that up and spread the word about the dangers associated with some products. And we share this information with the public. So that you can see on the bottom left is a list of products we found based on the country of manufacture, so that people can know that if they're using a product from India, they can check to see if it's been implicated in one of our heavy metal investigations. So doing this consumer product work is resource intensive. The surveillance, doing the store shopping is difficult in the sense that it's not all products list lead as an ingredient. There are many stores to survey. Often our surveillance efforts to get products off the shelves, they do get off the shelves, but then they return. So there's this recurring aspect of products. Enforcement is difficult in the sense that it's hard to not only get products removed from the shelf, it's hard to find the points of origin of purchase. So a lot of distributors that products being sold in New York City do not are distributed in from other states. So we don't have jurisdiction to take action to prevent those distributors from selling that product. And finally, there's a lot of cultural significance to these products, so it's difficult to get change of behavior based on this cultural significance of this product. So that's why we need to be culturally competent and provide alternatives that are not seen as an attack on culture or practices, but just as a way to protect health without sacrificing culture. And sorry. So if we want to stop this resource-intensive surveillance system, the only way to do that is to get the issue addressed in the countries of origin. Most of these products are manufactured outside the US. So we need to work with our global partners to find out why lead is being either intentionally or unintentionally added to products, and take action so that they can protect their citizens and protect our citizens and end the worldwide epidemic of childhood and adult lead exposure. And in order for us to have the data to support action globally, we need to do better nationally here in the United States of sharing data between jurisdictions. It's important that we try to come up with a national repository of all of the consumer product data. Lots of different jurisdictions are collecting it, but nobody's really sharing it in one space. So it's really, we're making efforts here in New York City to create a national repository as much as we can, given that we're a city. But it's really important that we combine our data. It's not only to share to help inform our investigations, but to inform the worldwide community. So you'll see that the first half of my presentation focused on lead-based paint, and you're maybe asking yourself, why focus on lead-based paint? A lot of it is because children spend most of their times indoors. Here in New York City and a lot of other jurisdictions have old housing that has lead-based paint. And really, it's because our investigations continue to identify it. It's the most commonly identified lead exposure source for the children we do investigations for, with over 70% of our children having an identified lead-based paint hazard. 25% have a consumer product risk identified, whereas the other potential exposure sources like water and soil are less than 5%. And we also see that children with the highest blood levels show evidence of lead-based paint exposure through imaging, radio-opaque masses in their stomach. So that's an additional evidence driving the contribution of lead-based paint on blood levels. And you'll hear more about this in presentations that come. Children with the highest blood levels often exhibit pica behaviors. Then those behaviors put them at increased risk because it leads to ingestion of lead-based paint and other lead sources.
It's now 10:50 and time to move along.
Okay. And so I think I'll just continue to make some arguments about focusing on lead-based paint. And this chart just compares private housing, which is older, to NYCHA housing, which is newer. And you could see a difference in the rates between children living in private housing, much higher than children living in NYCHA housing. And that also supports the argument that lead-based paint is often driving a lot of the child's exposure, a lot of children's exposure. And so in summary, closing, in a world of limited resources, we should try to focus our attention on the exposure sources that continue to be identified in childhood lead exposure investigations. And they continue to be identified because they have much higher concentrations. So for New York City, may not be in your jurisdiction, but we continue to see lead-based paint and consumer products as being a driver of childhood lead exposure. And in future policies should leverage the data collected by our local health departments to inform policies and budget priorities. And so here's some just quick resources for you for our data. You can see some of our data on consumer products, our educational materials, and an article about this national consumer product database. And I just want to close by thanking all of the staff of the Bureau of Environmental Disease Prevention who work every day to address lead exposure with Oh, this slide really got messed up, to address lead exposure. So I want to thank them. Without their work, we wouldn't have made the progress that we have. So thank you.
Thank you, Andrew. We've got a little bit long here so that we won't have time for taking questions. Everything that was written in the chat, we'll try to address if we have time at the end of today's conference. Otherwise, we will get back to you since all of your comments have a name associated with it. So I'm going to move on to our next speaker. This is David McAdam. He is an associate professor in the Division of Developmental Behavioral Pediatrics in the Department of Pediatrics at the University of Rochester School of Medicine. He holds a joint appointment at the Warner School of Education and Human Development, where he's the director of the master's degree program in applied behavioral analysis. His clinical and research interests include the functional analysis of problem behavior, like aggression, self-injurious behavior, and pica, evidence-based interventions for people with intellectual disabilities and autism, and parent training for families with autism, and the meta-analysis of single subject data. Dr. McAdam will talk to us about strategies for preventing and reducing pica. Thank you. David, you're on.
Thank you very much for that nice introduction. And I think we're going to start off with 3 questions as sort of a pre-test. And each question is going to appear on your screen for about 30 seconds. And I will answer these questions in my presentation. All right, just need a few seconds to call up my slides. All right, I'll give some time to answer this last question. All right, it looks like we're ready to get started here. Again, thank you for that very nice introduction. All right, today I'm going to talk about pica. Pica is defined as the ingestion or consumption of non-edible items. And professionally, I just want to tell you a little bit about my perspective before we get started, which is illustrated by these 2 pictures. So as a behavior analyst, I take a natural science approach to the behavior of people and really all the living organisms on the planet Earth. The first picture is of my daughter, Leah, who is Chinese and Tibetan, with our 2 dogs. So there's the black, white, and gray standard poodle. And there's the other dog who is a Springer Doodle, McCovey, named after the Hall of Fame first baseman of the San Francisco Giants. And from my perspective, in the perspective of a behavior analysis, it, all living creatures on the planet Earth are influenced by the same factors. These factors are our genetics and our biology and the history of what we learn in our lifetime. So our lifetime of experiences. And that's what shapes the behaviors that we display. And then the question is, I'm not saying that Leah and my dogs are identical, because Leah has language, and language allows us to pass on cultural practices from one generation to another. So today, I'm going to be taking a behavioral perspective to Pica, and there's a lot of complex behavior analytic language, but I'm going to avoid using that language in my presentation whenever I can. And when I do, I will define it for you in common terms. So pica again is the consumption of non-edible items. Pica is commonly displayed by individuals with developmental disabilities, elderly people with dementia, some elderly people with dementia, and people with particular medical conditions. So individuals with sickle cell anemia are likely to ingest foam, the stuffing out of a pillow, for example. In the developmental disability literature, most people engage in what we refer to as indiscriminate pica. So they eat a wide variety of non-edible items. And this is a list of some of the things commonly ingested: paper, dirt, large amounts of ice. In the Western New York area, in the wintertime, I see a lot of kids with disabilities that lick the rock salt off the bottom of their shoes and ingest it. And then what you're probably most interested in is items containing lead, which is predominantly paint chips. And at the bottom, I post the question, does the pica item ingested matter from a clinical perspective? And the answer is yes, because one of the things that we're very conscientious about in the treatment of pica is the possibility of medically related side effects. So for example, gloves are on the list, and non-latex gloves, when they're ingested, form a hard rock-like object in your intestine, and it produces a blockage, and typically they have to be surgically removed. So sort of, why, again, did we focus on the item ingested? In some cases, the item ingested suggests a nutritional deficiency, the need for environmental sweeps, checking the environment and ensuring it's free of items that the individual can potentially ingest. It tells us, if we're from a behavioral perspective, if we need to get medical consultation. One of the rules related to the treatment of pica with behavioral methods is that we typically require medical clearance, a check that there's the child is not, impacted currently, with objects that need to be removed. Oops. All right. Sorry about that. So there's various theories of pica. So why do individuals ingest non-edible objects? And I've listed them here in the order of their clinical importance to a behavioral perspective. So the three theories are a behavioral theory, a nutritional medical hypothesis, and also cultural practices. So from a behavioral perspective, we consider pica to be a learned behavior in the lifetime of the individual, and that we think it can be explained in terms of behavioral concepts, and that it can be assessed and treated using a behavioral analytic approach. And in behavior analysis, in some cases, we often conceptualize pica is the failure of the individuals in their ability to discriminate edible from non-edible items. And I'll show you some examples of using discrimination training to reduce the pica of individuals with disabilities and also individuals that ingest paint chips later on in my presentation. So from a behavioral perspective, when we're talking about challenging behaviors in general, so challenging behaviors are behaviors like aggression towards other people, property destruction, repetitive motor behaviors, and it would also include pica. We ask ourselves a very basic question, which is the form of challenging or problem behavior influenced by interactions with other people, or does the behavior occur independently of the social interactions with other people? And in the case of pica, at this point, there's numerous in the behavioral literature meta-analyses and systematic review papers on behavioral interventions to reduce pica. And one thing that's very nice is they all agree that pica is maintained by what we, so I'm going to use one of my fancy behavioral terms, what is referred to in the field as automatic reinforcement. Automatic reinforcement means independent of the presence and interactions with other people. You can think of automatic reinforcement as sensory reinforcement. You can also think of it as the individual finds something enjoyable or pleasurable about engaging in the behavior. And what's tricky clinically is, we don't have access. Oftentimes, we typically don't have access, particularly in the case of individuals with developmental disabilities, to their self-reports of their thoughts. So exactly what they find enjoyable or pleasurable is really hard to determine. There's a nutritional hypothesis of pica, and this hypothesis is that pica is related to an individual's nutritional status. And there's two types of deficiencies that we typically look for: iron anemia, and being deficient in zinc. And the support for this hypothesis of pica is there's a fairly large number of case studies and single case experimental design reports in the published peer-reviewed literature that demonstrates that once you provide an individual with nutritional supplements based on what their deficiency, pica is reduced. There's also some descriptions in the literature of, particular types of lesions or injuries to the brain that may produce pica. Go back here for a second. I didn't touch on the cultural hypothesis in my slides, but in case you're interested, the cultural hypothesis of pica is there's certain people, groups of people in the world, as part of folk medicine practices, ingest typically soils and clay and mixtures of soil and clay, oftentimes, but not exclusively related to pregnancy. And in the clinical diagnosis of pica, there is a requirement that pica occurs independently of cultural practices. So we're going to go on and talk about the behavioral treatment model of pica. And as a behavior analyst and taking a natural science approach to the behavior of people and all other living organisms on the planet Earth, behavior analysts are really concerned about using and focus on using interventions that we consider to be evidence-based. So all the interventions I'm going to share with you are considered in the field of behavior analysis to be evidence-based. So one of the things we often do is we assess pica, and we want to confirm that pica occurs independent of interactions with other people. And there's a variety of ways to do this. The gold standard way is a procedure called the analog functional analysis. And I'll show you a slide on this in a few minutes, and I'll also explain it to you in common everyday language. When we do our studies to evaluate treatments for pica, we do some things that protect individual safeties. We tend to use latency to the first occurrence of pica, which minimizes in the evaluation of the treatment how often the person has the opportunity to engage in pica. We also bait typically the environment with items that are safe to ingest. And typically these items are identified under consultation with a medical professional. So in the assessment of pica, we use the gold standard approach in behavior analysis. The highest level of assessment, the one we have the most confidence in, is called the analog functional analysis. And when I show you these graphs, I'm going to, all the data I'm sharing today has gone through a peer review process. It all appears in the published behavioral literature. And I'm going to give you the overall highlights. So in that analog functional analysis, what we do is we place the person in a situation, and we do a bunch of things to ensure their safety. And we typically bait the environment with things that are safe for them to ingest. And we're trying to answer the question, is there any evidence that the person engages in pica based on the way other people interact with them? Or is pica maintained by sensory consequences? So does it occur independently of our interactions with other people? In this assessment protocol, we set up a series of situations. One of them, when the person engages in pica, we give them attention. We're like, don't do that. Stop eating that item. We ignore the person for a period of time, which is a test to see whether or not the behavior occurs in the absence of interactions with other people. And we use a control condition. And this pattern of data, and then we alternate the conditions. We present them for 10-minute blocks of time in a random sequence. And this, you read the outcome of the analog functional analysis, sort of like reading an X-ray. And the standard interpretation of this mixed pattern of data is that the behavior that's being assessed is maintained by sensory consequences. So empirical evidence that pica occurs independently of interactions of other people. Want to share an example of the nutritional hypothesis of pica. So this is a 9-year-old girl who has a severe intellectual disability. So nonverbal, non-vocal, with minimal ability to understand what is said to her. And the intervention is vitamin and iron supplements. And the story of this study is that the authors, Pace and his colleagues, are working in a program for individuals with developmental disabilities that includes a school and group home. And they encounter somebody who they're told that pica has been reduced to providing nutritional supplements, iron and a multi-purpose vitamin. What they do in the first part of the study is they simply measure the person's rate of pica. They then take away, for the purpose of testing whether or not the intervention works, they take away one portion of the intervention. So they remove the multi-purpose vitamin. Pica returns. They then place the iron and vitamin supplements back in place. And pica again reduces to near zero levels. And the measure is latency of pica. So if the data is high on the graph, it indicates at the top of the graph, it indicates that pica did not occur. So evidence from the published literature that nutritional supplements, if a person has an identified deficit in iron or zinc, may reduce an individual's pica. The other thing we recommend a lot with individuals with pica is preventative strategies. So individuals with pica are very good at identifying items in their environment. And, in fact, they're better at finding things than we are at keeping the environment clean of potentially objects they can ingest. So from a clinical perspective, one of the first things I do if I'm working with an individual with pica is go to where they go to school, go to where they live, look around and see what is the availability of non-edible items that they have a history of ingestion. And places like classrooms and programs like group homes for individuals with developmental disabilities We often use a pica sweep form. So there's a rule in place that the individuals that work in the setting that support the individual need to check the environment for potential items daily. In some cases, maybe twice a day. And we use this type of checklist to do so. So one of the best strategies to reduce pica is to be as preventative as possible related to the availability of items. A while ago, myself and some of my colleagues did a meta-analysis of single case studies on interventions of pica. So what we did was we essentially looked at the literature, divided interventions into categories, and then we examined whether the size of the reduction in pica they produced. And there's some statistical methods to do this. And what I'm going to do is share with you some examples of interventions for pica that are evidence-based. So the first one is environmental enrichment. And again, all of these studies pass the peer review process. They all use behavioral data. And in behavioral data, we focus on collecting data at the level of the individual, and we collect repeated measures. So we're examining the behavior repeatedly over a relatively long period of time. And again, I'm going to kind of tell the story. So this case, Judy Favel in 1980, a very important study, because this study really produced a shift in the way we think about the treatment of pica and the behavioral literature. So individual, it was in a care facility. Again, they had a severe intellectual disability. And Judy Favel asked the very basic question: if we substitute and provide alternative activities or things that produce the same or similar source of enjoyment as engaging in pica, can we reduce it? So the thing they identified that might produce the same or similar source of enjoyment was making popcorn available non-contingently. And what they showed was that making the popcorn available, alternative item, reduced pica. And some toys also may have enriching the environment with preferred items, may have also contributed to a reduction in pica. On to the next study. One of the things we do in the behavioral literature is we teach people to use what we refer to as response blocking. So the individual who engages in pica is attempting to pick something up and place it in their mouth. And we teach people, you block the behavior with your hand, you remove the item, and then typically you prompt or encourage the person to engage in a functional activity, it's an alternative to the display of pica. And the question in this particular study is, one of the things people reported was response blocking kind of works sometimes and doesn't work at other times. And they asked the question about, when do we block it? How do we block it? Does it make a difference? And what they demonstrated was that in order for response blocking to be successful, you had to pick up the item, you had to block the person picking up the item at its earliest point. So if the person was reaching for the item on the floor, you blocked it and redirected them. Response blocking works. If you wait till the item's close to their mouth and block it, response blocking doesn't work. The explanation of what for this difference is simply blocking pica when the item is moving towards the person's mouth, or when they're going to place it in their mouth, is hard to do. The person's occasionally successful, and occasional success promotes the continuation of engagement in pica. So how we block makes a difference. Example of differential reinforcement, a very elegant, very fancy study, but I'm going to hit some highlights here for you. Confirmed that the behavior occurred, was maintained by sensory reinforcement. So again, occurs in the absence of other people. How the parents interact with the child doesn't make a difference in terms of their likelihood to engage in pica. They then identify items that compete with, very much like the Fable study. What are some alternative items that the person can engage in that will potentially reduce the display, the occurrence of pica? And what they find out is identifying items alone and making them available did not produce a clinically significant reduction in pica. Then what they do is they teach the person to respond to a prompt, an instruction, to place the item that they are attempting to ingest into a garbage can, or to hand it to a person. And then they reinforce or reward that behavior with a item that has been identified as being a potent reward or reinforcer for the individual. Point here is, always think about environmental enrichment, things that compete with pica. For some individuals, making those things available alone may not be sufficient. Another intervention approach that's been taken with pica, and this has been used with individuals that also ingest paint chips, is called discrimination training. So this discrimination training is based on the theory that the individual has difficulty identifying food items from non-food items. Provided the steps here of discrimination training. So essentially, in a structured teaching session, you have, say, a plate and foods on the plate, and in the surrounding environment, you have non-edible objects, and the person is reinforced or rewarded for only ingesting the items on their plate. If they attempt to engage in pica, it's blocked, and that behavior is not reinforced or rewarded. Couple examples. The first one is with individuals with intellectual and developmental disabilities, and discrimination training worked with these individuals. It's important to note that there is an additional component used. So when the individuals attempted to engage in pica, the therapist or the experimenter removed the item and wiped their mouth with a damp washcloth. So we can't conclude that discrimination training alone produced the effect here. It was produced in combination with those two procedures. Example of discrimination training used with individuals who ingested paint chips, done at Kennedy Krieger by Mike Cataldo with individuals in their lead treatment program. Again, discrimination training worked. Some of the individuals did require some additional components in order to produce zero or near zero levels of pica. In the pica literature, particularly the early literature, you do see some use of punishment-based procedures. And from a behavioral perspective, punishment is, we define punishment and think of punishment in a particular way. So punishment doesn't equate to good or bad. Punishment describes a situation where something is provided contingent on the occurrence of pica that decreases the future probability of the occurrence of the behavior. In behavior analysis, we have very stringent ethical standards. So we would not use a punishment-based procedure unless other potentially effective, less restrictive interventions were demonstrated not to work. And typically we would require approval and evaluation of a full interdisciplinary team. So we would not make the decision solely on our own. In this particular study, what they do is the child bites off pieces of plastic toys and swallows them. They identify that a low preference food item was tapioca pudding, contingent on breaking off the piece of plastic and attempting to swallow the item. The person is given, required to ingest a very small amount of tapioca pudding. The person, doesn't like the taste of tapioca pudding. Pica is reduced either through a punishment effect or by the fact that the person wants to avoid having to ingest the tapioca pudding. And in fancy behavioral language, we refer to that as negative reinforcement. There's so we don't have a lot of data on these for the treatment of pica, but I thought particularly relevant given the audience. So I suspect that, people may work with individuals who do not have developmental disabilities but engaged in pica. And there's some really interesting interventions that are evidence-based but not yet demonstrated to be effective with individuals with pica. So there's behavioral parent training models where you co-construct an intervention plan with parents and how they're going to apply it at home through a series of one-on-one teaching strategies. There's an intervention called habit reversal, which is very effective for behaviors like tics. And in habit reversal, you teach the person to self-monitor when they're engaged in the behavior. You help them identify what the behavior is. You define it for them, make it clear to them what's the behavior you want to reduce. And again, it's very effective in reducing habits and other repetitive behaviors. It seems like it would have a lot of potential for individuals that consume paint chips. And then the other one would be behavioral contracting, where you describe contingencies, where you agree with the individual on contingencies or rules related to their behavior, and rewards or reinforcers are available to them contingent on meeting the goals of their contract. And wrapping up here, a little bit of self-promotion. Myself and some of my colleagues, with support from the Autism Treatment Network, have published 2 guidelines for pica that are available to you for free on the internet. One's a guide for professionals, and then one's a guide for parents. And then I just want to wrap up and thank you very much for spending the time listening to me today. I know I covered a lot, and everybody might not be familiar with behavioral interventions, but I would be more than happy to answer questions you have if you contact me at my email address.
Thank you so much. I'm sure all of you are itching to ask questions. There are a lot of them in the chat, and hopefully we're going to have time to get to them at the end of the program. But it is time for a break. You are on your own until 11:45. So there will be no music during the interlude. You will not be missing anything. Do what you need to do to refresh yourselves. And we'll see you back for the next two talks at 11:45. See you then.
Have arrived as well. So Dr. Cassia Cordes is an associate professor in the Department of Epidemiology and Environmental Health at the University of Buffalo. She's also a faculty affiliate of the WHO Collaborating Center on Housing and Health at the University of Buffalo. Her training is in nutritional sciences, environmental health, and global health. Together with colleagues from Uruguay, Dr. Cordes established and co-leads the Salud Ambiental Montevideo cohort. They have been evaluating the health of school children and adolescents in relation to complex mixtures since 2011. Their work incorporates the influence of contextual factors such as family and neighborhood resources and disadvantages, and diet-toxicant interactions on multiple aspects of children's health, including cognitive development, behavior, and now also on cardiovascular health. Dr. Cordes will provide us with insights into the relationship between lead, nutrition, and diet, the good and the bad. Dr. Cordes, Cassia?
Yeah, thank you so much for this introduction. I will begin by sharing my presentation. And hopefully what you're seeing is my slides.
Yes.
Okay, wonderful. So good morning still to everyone. I'm Kasia Cordas, and as Dr. Markowitz said, I will tell you about the interconnections between lead, nutrition, and diet. I will divide my presentation into three themes that are related. I'll first talk about nutritional status in children's blood lead levels, then cover nutrient-rich foods and potential mitigation of lead exposure, and then food contamination, diet patterns, and lead exposure. So to start, we'll recognize that several age and population groups are vulnerable to lead exposure and lead toxicity, and this vulnerability coincides with periods of most intense growth and development. These periods include pregnancy, lactation, and early childhood. That's not to say that other periods are unimportant for lead exposure, but today we're focusing on children. So as this figure demonstrates, in the first year of life, children grow and develop to become self-propelled, thinking, complex, creative individuals who explore and communicate with their world. And so just as an example, by age 2, children almost quadruple in weight from the time that they were born. And by age 5, they can follow multiple part instructions, engage in complex imaginative play. But we also know that these developmental strides can be curtailed by early life exposure to lead. Children can be exposed to lead in from many different sources, but the way lead makes it into the body is through ingestion, which is most relevant to what I'll talk about today, as well as inhalation and skin contact. So this brings me to the first theme. Given that ingestion is the major route of lead exposure, we need to think about how children's nutritional status may relate to their blood lead levels. So this is, I think, best understood for iron status and iron deficiency. And I know that iron was mentioned in the previous presentation, so some of this will be a review. But it's been shown in numerous studies that iron deficiency may predispose children to elevated blood lead levels. And given that children grow rapidly in the first couple of years of life, and that this growth really requires a good supply of iron, it's not surprising that many children around the world, and even in the US, have insufficient iron intake to support their needs and may actually develop iron deficiency. So in this study that I'm showing here, infants at a pediatric clinic had 2 visits over a period of 3 years. And during that time, they were divided into 4 different groups. In one group, they had sufficient iron status at both their times, at both their visits. Then there were some children who were iron sufficient to begin with, and then developed iron deficiency later on. Another group was iron deficient to begin with, and then at second visit, they recuperated their iron stores and status. And then there was a 4th group of children who were iron deficient at both of their clinic visits. So this study looked at the likelihood of having elevated blood lead levels, which at the time of this study was defined as 10 micrograms per deciliter. And it's very clear that the infants who were deficient in their iron stores at both visits had 5 times higher odds of presenting with lead poisoning than children who had replete stores, who had sufficient stores of iron in their bodies. So this finding makes a lot of sense when we look at the underlying biology for explanation. So as divalent metals, both iron and lead are absorbed in the small intestine of the body, specifically in the duodenum portion. The walls of the small intestine, so we're looking on the inside of the intestine here, the walls of the small intestine are lined with structures called villi, which are further, and this is a villus, which are further lined with individual absorptive cells called enterocytes. These villi are closely connected to the capillary system, so to the circulatory system, and whatever is absorbed eventually makes it into our circulation. Lead specifically is bound to red blood cells and travels throughout our circulatory system to different tissues of the body where it will exert its effects. But when we take a closer look at the absorptive cell lining the villi, we see that these cells express different types of transporters to bring minerals into the body. And the minerals are iron and calcium, and there are specific transporters in our intestines for that. But lead has no physiological function in the body, and so it doesn't have its own transporters. However, it's an opportunist, and so it will use these existing transporters to get into the body. So in a situation when we have low supply of iron in the diet, the body will begin to express more of these transporters to try to fish out iron that's found in the intestine to help absorb more. But when lead is also present in the intestine from whatever source that it was ingested, it will use these increased number of transporters to get into the body. So again, it acts as an opportunist. And I think that helps explain the results that we saw in those children who were iron deficient at their clinic visits. So this also brings me to the second theme. Again, the prior illustrations strongly supports this idea that young children should be consuming nutrient-rich foods to prevent them from developing nutritional deficiency, because those nutritional deficiencies can then predispose children to developing lead poisoning. And so the Centers for Disease Control and Prevention has long recommended nutrient-rich diets to try and lower lead levels in children. Those recommendations have focused on iron, calcium, and vitamin C. Now, iron and calcium make sense from what I just showed you that is happening in the intestine. And iron and calcium can compete with lead for absorption at those specific transporters. Vitamin C, I think, needs a little bit more explanation, and it's recommended specifically because it can help absorb iron in the intestine. Vitamin C has also been shown to enhance calcium absorption and retention in the body. And of course, as children grow from birth to age, they have higher requirements for all of these three nutrients. Another nutrient that I want to mention specifically is vitamin D. And it's important to have it in the diet because it enhances calcium absorption and utilization. So that's, even though it's not part of the official recommendations, it is also worth focusing on vitamin D-rich foods. So just to give an idea of where some of these nutrients come from for the youngest children, here's a graph from a study on consumption of infants up to 12 months of age. And from about 6 months to 12 months, but certainly even up to 24 months, baby foods are a major source of nutrients. Although, of course, family and table foods become more important as children age. So, for example, infant cereals, shown here in blue, are an important source of both, or actually iron, calcium, as well as folic acid. And then as children transition to other types of foods, other milks and yogurts will also provide calcium. Vitamin C will come from multiple foods such as fruits, fruit juices, and fruit puree. So I'm telling you about foods and foods rich in nutrients because a couple of years ago, my colleagues and I conducted a study to understand if we could see those CDC recommendations for the consumption of iron, calcium, and vitamin C rich foods reflected in blood lead levels in children. And in fact, we could. So what I'm showing you on this slide is both a graph as well as a table that show the same results, but different people have different ways in which they like to see results from studies. So focus on whatever you would like, but I'm going to be talking about the graph. So we used data from the National Health and Nutrition Examination Survey that was conducted in 2009 and between 2009 and 2014, and we identified all foods that were consumed by children ages 12 to 24 months. And we divided these foods into different categories, such as milks and dairy, breakfast cereals, sweets, grains, and vegetables, which I'm showing you here, but there were also others. So based on these 24-hour recalls of diets that caregivers completed for these kids, we were able to divide kids into non-consumers, and those are shown here in 0. So they didn't consume any of these foods. And then for those who did have reported consumption on the day of the recall, we were able to divide them into 3 equal categories based on the range of reported consumptions. So what we found here, we're comparing different levels of consumption, and here we see blood lead levels of those children. And so we found that kids who reported, who had the highest reported consumption of milk, as well as breakfast cereals and vegetables, had lower blood lead concentrations compared to non-consumers, and certainly compared to the lowest consumption group. So the conclusion here is that the diets or the foods that children rely on for calcium and iron in their diets, as well as foods that are some kind of a vegetable, may be related to lower blood lead levels. But there's a couple of other things that I want to note. So first of all, even those kids who are consuming higher amounts of these beneficial foods still have a measurable blood lead level. So there is no complete prevention of exposure and no complete prevention of poisoning. And I think that's important to note here. A couple of other things that we've seen from the literature is that the timing of meals, as well as other practices and behaviors around meal times, may be important. So, for example, although much of these studies come from adults, we believe that absorption of lead in the intestine may be lower when the period between meals is shorter, and so we believe that more frequent, if smaller meals, may be helpful for children as well. There were a couple of studies in preschool children that showed that regular breakfast consumption was also related to lower blood lead levels. And then similarly with these behaviors around eating around the time of meals, because lead sticks to hands, hand washing before meals or snacks will be an important preventive measure, especially for those children who are still using fingers to eat. So in sum, for this section, I want to say that nutrient-rich foods, and I named 4 nutrients: iron, calcium, vitamin C, and vitamin D, are related to lower blood lead levels. But we also need to acknowledge that those effects are going to be, on average, modest. And again, just to reemphasize what I said earlier, diet alone doesn't prevent or mitigate lead poisoning because lead comes from non-dietary sources, and lead may be absorbed in multiple ways. So just to go back to this villus that I showed earlier, even if lead does not use these transporters for iron and calcium to get into the body, it can get into the body through these gaps in between cells. So it can also have other ways of getting through the intestinal wall and into our circulation. And this is, again, another explanation for why dietary approaches may be helpful, but alone are not sufficient to prevent lead poisoning. So I want to get into now this third theme, which I think we've mentioned a little bit previously with pica, and I saw just a bit in the chat about spices. So you've probably seen these reports from consumer groups, as well as alerts from the Food and Drug Administration on lead in cinnamon in foods, as well as cookware. And it feels really alarming because these sources contribute to children's ingestion of lead. And so I think it's important to unpack a little bit of what's going on. But you haven't had your poll yet in relation to my presentation. So let's do that now. Let's take a break. And there are 2 questions to answer. So if the first one could be displayed, please. So take a few seconds to respond. All right, maybe let's stop now. And the second one? Okay, I hope you've had a chance to respond. We're going to close that in 2. Please go ahead and close. All right, so I wonder if we could just display those responses. All right, so in the past 3 months, a lot of you are using cinnamon less than once a month, or maybe 2 or 3 times per month. So to take a picture of that just so I remember when we talk about it. Okay, and then can we see that the first? Please go ahead and close that, and maybe we can see the responses to the first question, if they're available. All right.
I don't
Well,
know if he can go back,
no,
but
that's okay. We're in the
the-
interest of time, we'll just keep on going.
the fall and year round were the 2 most heavily
Oh,
checked.
okay. That's great. We'll come back to those responses soon. I will be incorporating them a little bit. Yay, there we go. Okay. So I'll incorporate them soon into my discussion, but we're going to keep on going. So I want to get into contamination. So there are many different ways in which lead can get into our foods. The first one is lead occurs naturally in soil. So when food crops such as vegetables are grown in soil that contains lead, some of those vegetables will absorb lead. Different vegetables vary in terms of how much lead they will be absorbing, so it's not uniform across our vegetables or fruits. And also, soils across the world have varying amounts of lead. So vegetables grown in different fields or even different parts of the same field may differ in terms of their lead content. But I also think it's important to acknowledge that our human activity contributes greatly to the pollution and the way that lead can get into our foods. So that includes air pollution, water pollution, industrial activity. Cookware is also important, and I mentioned that on the first slide that when in this theme. So of the type that the FDA has been recalling, the aluminum cookware, but also losa vidriada, which is a traditional cookware used by Mexican families, those can contribute to both adults and children having higher blood lead levels. And that's a picture of the losa vidriada. So the Food and Drug Administration in the US has been tasked with monitoring contaminants, including lead, in the US food supply. So this monitoring occurs periodically and is done through what is called the Total Diet Study. The latest study of this type was conducted between 2018 and 2020, and there were 342 types of foods that were purchased across different regions of the United States. Then they were prepared for consumption. For example, they were either boiled or fried, sort of in a typical way, and then they were sent off for testing at a central laboratory. So given what I've said so far, you're not going to be surprised that lead was found in some of these foods that were tested. The unit in which this was reported is called parts per billion. Another way of thinking about this unit is nanograms per gram. And since I'll be talking about these units, I just want to explain what that means. So think about a grain of sugar represented here by this circle on the very left of the screen. I think it's left. It's left on my screen. So think about this single grain of sugar, and 1 part per billion is that 1 grain of sugar in 61 tablespoons of sugar. So that gives you an idea of what we're talking about when we say 1 part per billion. So now to the results. So in the US food supply, about 14% of foods that were tested, of those 342 food types that were tested, had a detectable lead level. Most of those levels were low or very low, as is shown right here, with values bunched together and close to 0. In 2023, The Food and Drug Administration also measured lead in 359 baby foods sold on the US market. And the mean values are shown here. Again, this is in parts per billion. And the lower values were found in fruits as well as dairy products, and higher values were found in vegetable and grain products. Okay, but this is not the whole story, because what children are exposed to, the exposure from diets, actually children and adults, this depends on how much lead is in the food, which is what we just saw in the previous slide, but also how much of that food is consumed, and also on the frequency of consumption. So how often is that food consumed? Additionally, we already talked about the intestinal tract and what's going on there. Not all lead that we ingest is absorbed, because as we saw previously, iron, calcium, and other types of nutrients will be competing for absorption. So lead, for example, lead that is bound to fiber will also not be fully available for absorption in the intestine. And unfortunately, in children, we're not so very certain about how much lead is absorbed when it is in the intestine with food, but it will be a smaller fraction, perhaps half of what is ingested. So oftentimes, the food that contains a higher amount of lead is not necessarily the food of greatest concern to us. So for example, in this particular study, researchers looked at all the different foods that were tested as part of the total diet study, and based on dietary recalls from the NHANES, they calculated how many grams of these different foods children consume. These are plotted here in broad categories, and together they add up to about 1,500 grams. Then what they did is combined the information on grams of intake with the amount of lead that was measured in each food, and they found this. So because dairy and fruit actually have higher level of consumption, children consume more of those, they contribute more to exposure compared to some other foods. So the message here is the numbers are not so important. Again, remember, food can come from different fields, and so it will have different values. The numbers here are not so important. The message here is that it is not sufficient to know how much lead is in a given food. You really have to understand how that food is consumed, how often, and how much. And that's going to differ for different children, different cultural backgrounds, and so on. So foods that are consumed daily, such as our staple foods like rice, may actually contribute more to exposure. So let's go back to our survey. Most of us consume cinnamon either in the fall. There was quite a large consumption of year-round, but when we also asked in the past 3 months, how much did you consume? Most of you responded you used cinnamon less than once, or maybe 2 or 3 times per month. So when we have lead in a food like cinnamon that is consumed less frequently, it will be of a lesser concern than lead for foods that are consumed year-round or on a daily basis. So at this point, I want to emphasize that lead levels in the US food supply are on the decline. And when we look at lead exposure from foods in the US, we see that there has been a drastic decline since the 1980s. And that's good news. But there's also more to say. Up to this point, we've been talking about individual foods or food groups. And I think it's important to also think about diet patterns. And diet patterns are the combination of food and beverages which we consume daily or weekly, and together they probably influence our health more than any single food. So my colleagues and I wanted to think about how patterns of eating could be affecting exposure of children to lead from their diets. And so we took a sample menu for children ages 8 to 12 months. This covers foods, different types of foods from breakfast to bedtime, and different amounts depending on the stage of growth and requirements and so on. And what we did is and of course, these can be tailored to different appetites and cultural backgrounds and family circumstances. But what we did is we took the foods that were measured for lead levels in the total diet study, and we designed a diet for 4 days. The details here are not really that important. What I want to just say is that we repeated some foods because that's how children eat, but we also tried to vary them from day to day. And so what we saw for lead is that on a daily basis, there was, so average intake is right here, and then intake on each day of the 4 days is in blue, red, yellow, and green. And then again, average is orange, excuse me. So what we saw is that over the 4 days, the average was, for the most part, similar to or lower than some of the days. We also saw that the average, that all of the days, but also the average, was below the Food and Drug Administration reference value for dietary intake of lead. And what's also interesting is that this worked for other heavy metals. So it doesn't only seem to work for lead, it works for arsenic and cadmium. So as the dietary intake of children is varied over time, that is one way to lower their exposure to lead and heavy metals over a longer period of time. A couple of assumptions that we made here are listed. We looked at milk intake from formula, and also used a mix of baby and family foods that were either cut up or pureed. So we can also think about diet quality overall and ask whether overall, if children are eating a good quality diet every day, could that also have an impact on their lead levels? And there are no studies that look at this really directly, but there are 2 studies that could help us think about this question, and with hopefully more coming in the future. So in this study on the left, my colleagues and I rated school children on the quality of their diet. So we looked at variety, adequacy, moderation, and then gave them an overall score. Higher scores meant better diet quality. And before I talk about the results, I also want to say that these kids did not have the highest quality diets. So who knows what this would look like if their diet quality was optimal. But what we saw is that when we related these diet quality scores to children's blended levels, we saw that they were essentially close to 0. There was almost no effect. That meant that better diet quality didn't lower lead levels, but also it didn't make them higher. And again, from these school children in particular, we know that they have lead in their diets. In another study of preschool children in Spain, researchers rated children on how well their diets adhered to this Mediterranean diet style, and they gave them 0, 1, or 2 points on the consumption of vegetables, fruits, and cereals. They measured different metals in urine, but I'm also only going to show you lead levels right here. And again, they showed that there was no relationship. The relationship was essentially 0. depending, regardless of how high or low their consumption was of these different components. Again, this is not a perfect way of answering the question, but it gives us some potential ideas. So I want to start wrapping up here my presentation to show you this way of thinking about the relationship between heavy metals and lead in particular in food and children's health, and just recognize how complex this is. So it's difficult to think about these multiple parts for which some of which we don't really have a lot of evidence. But to understand if heavy metals in foods affect children's health, we first need to understand whether they would result in having a higher lead level. And we don't really understand that yet, although the two studies I showed you before give us some clue, maybe. We also need to acknowledge that dietary nutrients in those foods, as well as children's nutritional status is going to affect this by affecting how much lead is absorbed. We also need to acknowledge that there's all of these other sources of lead that will also contribute to how much lead is in children's blood. And then going from here to children's health, again, we need to think about how nutritional status and deficiencies may be affecting children's health alone. And of course, nutrients are beneficial. We eat foods because they sustain us. They provide the essential nutrients that we need for healthy growth and development. So that will play a role as well. So I'm looking forward to your comments and questions, but I have some takeaways. And all of this, I will say, is subject to change as we gain more knowledge about this topic. So heavy metals are found in foods across the globe, but lead levels in foods in the US have declined drastically. The exposure dose for dietary metals and lead is really difficult to quantify because we don't have a lot of information on this. And the effects of lead exposure from the diet on children's health is not well understood. Children need nutrients to grow and to develop in healthy ways, and we need to prevent nutritional deficiency, iron in particular, starting from infancy. And then nutrient-dense foods that are part of a healthy diet pattern may help mitigate exposure. And there, I think diet variety is critical. So I think that's all I have. Thanks so much for listening, and I'm happy to have a discussion.
Thank you, Kasia. There is a question for you, and I'll read it to you. It starts off, thank you, Kasia. In a dietary approach to mitigate lead absorption and toxicity, how important is that children avoid skipping breakfast and that they break fast or breakfast with nutrient-rich, meaning iron, calcium, vitamin C, vitamin D foods? And would you add zinc to this list?
Mm-hmm. That's a really good question. Thank you so much for asking it. Yes, from what we've seen, there aren't very many studies on breakfast skipping, but at least from what we've seen, I think breakfast is important. I think for very young infants, breakfast is a little difficult to define because especially with breastfeeding or formula feeding, there's meals in between and the meal timing changes. But for older children, for older infants and for preschool children for whom breakfast is more of a defined meal, I think it really is important to have breakfast and to include nutrient-rich foods, so iron-rich foods, calcium-rich foods. And yes, zinc is important. There isn't as much research on zinc with respect to preventing lead exposure, but regardless, kids need zinc to grow in healthy ways and develop in healthy ways. So that would certainly be consistent with the developmental needs of children.
I think if I may, I would add to that that copper, which hasn't been mentioned in any of the talks, is probably also a player. similar to other essential metals that have been discussed. I think the implication of the question also was that the potential absorption of lead from any food on an empty stomach is likely to have a greater percent absorbed because you're missing all of the competitors that come in that food.
That's true.
Okay, well, that was right on time. Excellent.
Thank you.
Thank you. We'll move on now to our last speaker. And the order of the sequence of the presentations today, I think are pretty clear to members of the audience. And we started with concerns about sources of lead and how you reduce them, realizing that we've really put too much lead out there to completely eliminate exposure, but we have markedly reduced it. And that second, it isn't the lead in the room, it's the lead that gets into you that counts, and that's the pathway. How does it get into you? And for kids, it's through the mouth. So changing non-nutrition related behaviors should help to mitigate the amount of lead that ends up staying in the body to cause harm. And then third is, well, it isn't the lead coming by itself typically, but it may come with things that we're supposed to eat. And how much of a risk is that? And should we consider it? And also that once the lead is inside, if you're deficient, the harm and the ability to remove it increase. So if you fail in all three steps, what we've developed since the 1940s are drugs to remove lead, to enhance the excretion of lead. And unfortunately, we got stuck somewhere in the 1980s with the development of the drugs. And we only have drugs that are available for very high levels of what we consider currently very high levels of 45 micrograms per deciliter and higher. And our last speaker is the expert on chelation. And I think for me has raised hope that we're going to be able to move off this wall we've encountered at efficacy of drugs being only above 45 micrograms per deciliter of blood in kids or in adults. So the introduction for Michal Mazal-Shoshan. She earned her PhD in medicinal inorganic chemistry at the Hebrew University of Jerusalem, where she focused on copper binding peptides for both mechanistic insights and therapeutic applications. Following postdoctoral research at ETH Zurich, she established her own research group at the University of Zurich, aiming to transform chelation therapy by using short, bio-inspired peptides. Her team initially focused on lead poisoning and developed novel peptides that, in preclinical studies, outperform the standard of care, even at low initial blood lead levels. This promising technology led to the founding of MetaLead Therapeutics AG, a Swiss biotech company spun out of the University of Zurich, where Michal now serves as the founder and CEO. Dr. Shoshan, the floor is yours.
Thank you very much, Maury, for the kind introduction and for the invitation to participate in today's session. I'm excited in being here today. Let me quickly share my screen. And in the meanwhile, maybe it's the right time to post the question that I've been having for all of you. That would be great.
While you're reading, excuse me, Michal, while you're reading the question, I didn't indicate that Michal is presenting from Switzerland.
Correct, where it is quite, it's 6 p.m. right now, but that's totally a legit time. Great, so a few more seconds for you to answer and shed a bit of more light about the needs. That would be great. Good, and I think we can move on with me sharing with you our insights from about almost a decade of research in our attempts to redefine chelation therapy for the treatment of lead poisoning. Before I move on to my talk, I do want to provide you with a disclosure of my potential conflict of interest. As Dr. Markovic has mentioned, we are now working in a company setup. So clearly there might be a financial conflict of interest in this regard, but other than this, the data that I'm sharing with you is clearly valid. And with that, we will have a lot of chemistry flashbacks to your studies. I hope that it will ring the bell. And we will start with a quick definition and a quick reminder of metal chemistry and metal biochemistry. So what we see in front of us is the periodic table, which summarizes all of the 100 plus different elements. And usually, I think that the typical division in the periodic table is between metals and non-metallic elements. While the non-metallic, I've been marking them in orange, the metals are actually occupying the vast majority of the periodic table, marked in green. And there's plenty of different ways to define what metals are and what non-metal elements are. But I would stick to the most simple definition, where metals are elements that are readily capable of losing electrons to form cations, which are positively charged ions. And also they have the possibility of forming metallic bonds in between each other. Whereas the nonmetals are elements that tend to gain or share electrons in chemical reactions rather than losing them completely. And of course, that's overall a very wide definition, clearly with a lot of exceptions. But let's, for the sake of this talk specifically, agree on this particular simplified definition. And the reason why we start with such an overlook is because lead is clearly a metal. I marked it here in the periodic table. So Pb stands for plobium in Latin, which is the symbol for lead, chemically speaking. Now, if we go a bit broader than this, and this has been a topic in various talks today in this conference, and when we speak broadly on metal toxicity, we usually categorize them from a chemistry perspective into two different classes, such metals. The first of one is, of course, the non-essential intrinsically toxic metals, the ones that we should not have in our body. Lead is, of course, one of which, but there's also cadmium, arsenic, mercury, and many others. And the other class of toxic metals are metals that are considered to be essential, but if they undergo misregulation, often linked to genetic malfunction, they can cause different types of diseases. Practically every metal that we have in our body, which is considered to be essential, is linked to at least one human pathology. In this category, we speak about iron, calcium, copper, and so on. Now, all of those metals, so either essential but misregulated metals or intrinsically toxic metals, in many of those cases, proteins have been evolved in millions of years of evolution to address metal regulation, metal homeostasis. There's different types of proteins, and I will just name a few examples of such proteins, such as, for example, metallothionein, a well-known investigated protein that is existing in the ingestion system of humans, but also in practically every organism that has been investigated so far, and is responsible for the regulation of zinc in our gut. Another example is a very known protein called transferrin, responsible for the transportation of iron in the bloodstream and the balance of this extremely essential metal. And of course, there's plenty of other examples, but as you can see here, there's no example known today to the scientific community of a protein, not so to say human protein, that is participating in lead homeostasis or lead regulation or even lead detoxification. And the reason for this is very simple, or at least the hypothesis for this is very simple. We've been exposed to lead for a short time, or at least shorter time than what is required for evolution to kick in and to start evolving complicated and complex structures such as proteins. So there's practically no known protein that is participating in the detoxification of lead, not in humans as well as not in other organisms. So the only way that we, as medicinal chemists, have to address metal regulation or lead poisoning specifically is by administering chelation therapy. Because as has been mentioned by Maury and others, once a human is being poisoned by lead, the only way of getting rid of the toxic metal is by an active excretion, which is generated exclusively by chelation. And there's about, give or take, 20 different small molecule drugs approved for the chelation of various types of metals. Only a few of them are for lead, but other metals are also in this category. And if we look at all of them from a broader spectrum, we can conclude that none of them is actually fulfilling the requirements from chelation therapy or from chelating agents, as they are as their metal affinity as well as metal selectivity, their ability to distinguish between the metal ion of interest without binding to the different types of metals that we have in our body. Those abilities are quite quite poor, and this practically reduces significantly the efficacy of those drugs as well as increasing their toxicity. So what we've been doing in the past decade or so, specifically about lead poisoning and more and longer time for other metals too, was to look at how nature addresses metal regulation, metal homeostasis disorders. And as I mentioned, it is always based on the peptidic scaffold, let it be proteins or peptides, and we'll define peptides in a minute. So that brought us to the realization that it might be that the solution lies within the peptidic chemical space. So our solution that we are offering is very, very simple. We're offering short peptides as the class of chemical space that can benefit from both of the worlds. They can benefit from high specificity, similarly to proteins, in terms of how to identify and how to bind exclusively to the metal of interest. But they also benefit from high oral availability and high stability, similarly to small molecules. We often know that peptides and proteins are practically, we cannot administer them orally clearly. So really cherry picking the advantages of both of the two chemical spaces without the limitations. And that's precisely what we are currently working on, starting from an academic setup and now moving on towards a venture. So before we dive in to show you a bit of results that we have acquired specifically for lead, I do want to quickly give you an overview about what peptides are. Peptides are polymers, or let it be more precise, oligomers of amino acids linked by an amide bond. We also often call this bond a peptide bond. So if we take two amino acids and link them together to generate an amide or a peptide bond, which is marked here in the blue box, we get a peptide. In this case, this is a dipeptide, but all it requires is two amino acids to be able to call it a peptide. And clearly, this is also the definition of proteins. Peptides and proteins have the exact same backbone. We can go into philosophic discussions about when does a peptide end and a protein start, but for the sake of time reasons, we'll skip this discussion. The bottom line is that peptides are participating and are existing in so many different ways of life and can affect our life in many different ways. And I just name here a few classes of peptides. For examples, hormones. So this specific peptide is oxytocin that is participating in birth giving, in labor. Another examples is in antibiotics. For example, vancomycin, which is a very known antibiotic that is also that exists also, of course, developed by microorganisms, but is now exists as a drug. A lot of the different toxins of different toxic organisms, are also, of course, based on peptides, and this is all often being used in research into generating new chemical entities inspired by those peptides and generate pharmaceuticals, such as this example. It's called octreotide that is used in oncology. And lastly, if you tend to drink different types of dietary drinks, such as Coke Zero and so, you're also consuming on a daily basis, I guess, if you're like me in this regard, you're also consuming a peptide. In this regard, this peptide is called aspartame. It's a dipeptide that is substituting sugar. So peptides, I hope you all agree with me, are extremely important to various fields in our life. Now, not only the examples that I've been showing you, peptides participate in. Actually, peptides are one of the strongest toolkits of nature in metal regulation. And I've been drawing here a few examples of such peptides, very, very sophisticated structures, and I will just guide through some of them. For example, I think the most known peptide that exists also in us humans, it's called glutathione, which is the one I mark here right now. Glutathione is a tripeptide, so contains only 3 amino acids, and it is abounded in our body in high concentration, almost the same concentration of glucose in cells. And it participates in different types of roles. It has a lot of different responsibilities, among others to bind to copper, to zinc, cadmium, and mercury. But unfortunately, it is a very poor binder of lead. Phytokeratins, which are often found in bacteria as well as in plants, which is the one on the right top corner, is very similar to glutathione. It's just an oligomer of glutathione, and it is binding to different types of metals, including lead. But as said, this peptide is not found in animals, including not in humans. I want to bring 2 more examples of brilliant systems that have been evolved to address the need for importing essential metals into different organisms, mainly bacteria. Starting from the left down side of my slide, you could see 2 examples of peptides that are called siderophores. These are peptides that are binding extremely strong to iron, since bacteria require iron for their function, similarly to us, and they fight over this source. So they have evolved extremely complicated systems so to be able to increase iron uptake into their cells. And the same goes with copper and methanobactin, the peptide on the right bottom corner, that is acting exactly the same. So it's called a methanophore. It provides copper, it enables the inclusion of copper into bacteria that require copper in high quantities. So the take-home message from this is very simple. Peptides have the capability of binding to metals if we design them carefully, either by evolution or by rational design. They can bind to various types of metals. And not only this, they can bind selectively to one metal, distinguishing between, let it be iron, copper, or in our case, lead, without binding to the different types of other metals that are in surrounding. And it brought us to ask ourselves a question: can we translate the same success that has been achieved by nature with the siderophores and with methanobactin? And can we do the same in the lab for lead? So let's see what we have managed to achieve. But before that, although I'm pretty sure that this particular audience is quite convinced about the cause and the problem, I do want to give you a bit of an overview about what motivated us. So what motivated us was the realization that even in 2017, when we started this research, more than 1 million deaths are attributed directly to lead poisoning on a global scale, where UNICEF has determined that every 3rd child is poisoned by lead, having above the World Health Organization threshold value of 5 microgram per deciliter. This by itself was a great motivation for us to address this challenge. Now, if we zoom into the United States, it will not be a surprise to you that the CDC has determined in 2015 that about more than 3% of the American children have elevated blood lead levels. Depending on the threshold, it's slightly before the CDC has reduced it to 3.5. Now, the mechanisms by which lead is poisoned, there's various types of reasons why it is a poisonous metal, but I will try to give you an overview about the molecular reasons. First and foremost, it is replacing essential metals in active sites of endogenous metalloproteins and metalloenzymes. And by doing so, it deactivates those enzymes. And I think the best example for this is an enzyme called ALAD, and you see the structure here in front of you. ALAD is participating in the biosynthesis of porphyrin, which is a part of hemoglobin. And as a result, lead poisoning is causing an anemia because this enzyme requires zinc, but zinc is replaced by lead, and as a result, we don't have porphyrin biosynthesis anymore. In addition to this, lead is replacing calcium ions in the central nervous system. Calcium is an important neurotransmitter, and lead is crossing the blood-brain barrier by just mimicking calcium. They are very much similar in many aspects, and as a result, lead is penetrating into the brain, the most delicate organ, and causing, of course, and acting as a neurotoxicant. And lastly, it is also reshaping different types of protein, not necessarily proteins that are binding to metals. It is reshaping them, sometimes irreversibly, due to undesired binding that is often extremely tight, and as a result, practically deactivates those proteins and jeopardizes their function. Now, there's 5 chelating agents approved by the FDA. The structures are in front of you. So even though 5 are approved in the practice, in reality, 3 out of the 5 are no longer in use because of high toxicity and poor efficacy. And the only 2 that are in the clinic, called DMSA on the left side and EDTA on the right side, both of them are still, it's a compromise. They are far away from how we define an ideal chelating agent for lead poisoning should look like. And why is that? Because first and foremost, all of those compounds, including the 2 that are still in the clinic, are suffering from poor metal selectivity. As a result, but also due to other reasons, they are highly toxic. They have low cellular uptake, so they cannot penetrate into cells. They are practically only in the circulation. And in some cases, especially in the case of EDTA, they are suspected to cause metal redistribution, which means delivering the toxic metal into, for example, the brain, which is actually extremely paradoxical when it comes to aiming to remove lead from the brain. So going back to what we know about those standards of care is that while the WHO defines a threshold from which an intervention needs to take place as a 5 microgram per deciliter, and the CDC reduced this value about 4 years ago to 3.5, in reality, the 2 standards of care are proved to be used in much more elevated levels, in 45 microgram per deciliter in the case of DMSA or TSEMET, and 70 in the case of EDTA or Versenate. There were attempts in the late 90s to introduce DMSA at lower blood lead levels, at the 25 microgram per deciliter blood lead level among children, with the TLC study. But we all know how it ended up, and eventually it seemed to be not successful at all. So those drugs are non-efficacious at low blood lead levels. But in reality, the vast majority of the children that are exposed to lead, that are poisoned by lead, are not suffering from the blood lead levels that can be treated. In fact, and these are results that I just took from 2022 from the CDC report, we could see that among 30 different states in the United States, most of the children, above 95% of the children that were diagnosed suffering from lead poisoning, actually have blood lead level that is below 45 microgram per deciliter. And these are children that are not eligible of receiving any treatment. So in reality, yes, there are standards of care, but actually when it comes to action, there's barely anything to give to those children as well as to adults. And the reason for this is very, very simple. I've been talking several times about the need for metal selectivity. It's I think very, very clear to comprehend the realization that when a person is poisoned with lead, and depicted by the illustration on the left side, lead, if we do not treat with chelation, lead will stay in our body, will not get out of the body without active chelation. Now, an ideal medication should remove lead and lead only, while keeping all of the essential metals in our body, calcium, iron, copper, zinc, and many others, keeping them intact. And the reason for this is why don't we want to deplete the essential metals? Very simple. First and foremost, depletion of those essential metals could be related to toxicity. But in addition to this, if our drug is binding not only to zinc, but is binding also to other different metals that we have in our bloodstream and in our cells, the concentration, the dose of the drug will need to be increased and the efficacy will be significantly jeopardized. That is why metal affinity and metal selectivity are key aspects in those drugs. But in reality, the two standards of care are poorly in their ability to distinguish between lead and the different essential metals. And as a result, they deplete much less lead than we want them to deplete, but they also deplete quite a lot of the essential metals from the body as a result of treatment. And this has been clinically translated into the fact that only above 45 microgram per deciliter, we can start treating those patients. So the way that we have started our research is by first and foremost looking at lead from an inorganic chemistry point of view and from a physical perspective, and identifying differences, searching for differences between lead-2, which is the most abundant oxidation state of lead in biology, and looking at the competitors. And the competitors that we attribute to lead are calcium-2, copper-2, and zinc-2. These are the three most significant competitors in the physiological environment. And the size of those circles is actually representing the what we call ionic radius. How big is the ion? So clearly we could see that calcium and lead are very much almost the same. There's a few picometers differences between those two metal ions. That is why it's very hard for the different calcium channels in the blood-brain barrier to distinguish between those two. In addition to this, there is a whole theory in inorganic chemistry called the hard-soft acid-base theory. And we can also harness these differences between the different metal ions in our favor to be able to generate metal selectivity. And lastly, lead-2 ions have a very unique geometrical feature since they have a lone pair, an electronic lone pair that participates in the coordination and causing a hemispheric geometry that could be used in our favor to generate, again, metal selectivity. So taking all of this into account and some other characteristics that we are aware of, we compiled a list of what we define as the design principles. We concluded that our peptides should be short, head-to-tail cyclic, so that the affinity could be increased by reducing the enthalpy, with at least two soft to borderline metal binding entities, and where the ligands are facing the same direction so that we can capture lead in the hemispheric coordination geometry. A lot of chemistry words, my apology in advance. As a result of this, we were able to design peptides that are tailored for, generally speaking, each indication. But if we speak today about lead, our peptides are tailored to the ionic radius of lead, to the nature of ligands that lead prioritizes, to the preferred geometry, in the case of lead, the hemispheric geometry, with the desired coordination number. We can cross the cell membrane. We are still checking if we can cross the BBB, but nevertheless, as you will see in a minute, we can deplete lead from the brain of lead-exposed mice. And we really enable eventually the extremely efficacious urinary depletion of lead. So we've been testing more than 70 different peptides by now and tested each and every one of them. And the way where we started was to take human cells, treating them with lead in a concentration that kills at least 50% of the cell population. And then 1 hour after introducing lead, we started treating the cell culture with each and every peptide that we have synthesized. In this case, you see in front of you only the 3 best performing peptides, MTL1, 2, and 3. And in gray shades, you see the two standards of care that are used in the clinic to treat lead poisoning. What we've been following after is our ability to recover the cell culture viability at the end of the treatment. And as you can see, those three peptides are superior to the standards of care in recovering the cell culture, up to 4 times better recovery compared to the two drugs that are in the market. And the reason for this is, again, metal affinity and metal selectivity. For example, in the case of MTL2, we check the affinity to bind lead-2 ions, and the affinity is within the low nanomolar range, which is significantly higher than the affinity of the different standards of care. When we compare the methodology, it's important to mention that the methodology is very critical when we measure affinity. And also the metal selectivity. So for example, here, when we incubate the complex that is formed between our peptide and lead with either zinc or calcium, and bear in mind that we are incubating the complexes with 10 equivalents of zinc or 100 equivalents of calcium to mimic the physiological environment and the concentrations in the bloodstream, we can see that the complex is kept intact, which means that MTL2 in this case does not replace lead with calcium or with zinc. There's practically no interaction between those two essential metal ions and our peptide, and the complex integrity is not being jeopardized. So then we decided to take two peptides into to test them in mice, and these are the results that I want to share with you right now. So what we've been doing was taking wild-type mice, healthy mice, exposing them to lead via the drinking water for 7 days, after which they received once daily a treatment by oral gavage. So we gave them the drugs by gavage once daily for 7 days. At the end of this treatment, we terminated the mice, collected organs, but also during this study, we also collected urine and feces as well as blood. Let's start with what is going on in the blood, and this is the graph on the left side. We could see that after only 7 dosages, MTL1 and MTL2 managed to reduce significantly the blood lead level compared to untreated animals, so mice that were exposed to lead but received no treatment, as well as compared to the mice that were treated with DMSA or CEMET. And most importantly, in my opinion, is the graph on the right side, is when we look at the urine. So we collected urine in specific days from each and every mouse and measured not only lead in the urine, but we also measured, starting from the left to the right, we measured calcium, copper, zinc, and iron. And in all of those cases, what we concluded was 2 important conclusions. First, our 2 peptides do not deplete the essential metals. There's no excretion of the essential metals. And this is something that unfortunately we cannot say about the DMSA that is depleting copper and zinc. And second, our peptides manage to increase lead excretion significantly more, about 200% more compared to the standard of care. And then we also collected organs, key organs from those mice. From left to right, we collected brain, kidneys, liver, and femur as a representative of bones, since we know that lead is deposited into bones. And we were able to see that in all of those cases, lead organ burden is reduced significantly by more than 50%. Now, this happened in conditions that mimic elevated blood lead levels, so blood lead levels that resemble 45 microgram per deciliter in humans. What happens when we expose the mice to lower blood lead levels? I think this is the most important unmet medical need. So we repeated the exact same study, this time only with MTL2, but with 3 different groups of mice. Mice that were exposed to high levels of lead in their drinking water, medium levels, as well as low levels. And we conducted exactly the same study, collected blood, urine, as well as different organs. And based on this, we have concluded that regardless of the initial level of exposure to lead, In all of the cases, even at low initial blood lead levels, MTL2 manages to reduce blood lead level and through urinary excretion significantly more than, of course, untreated mice, as well as the ones that are treated with DMSA or TSEMET. So this is clearly an indication that even at low levels of exposure, our MTL2 specifically can be extremely efficacious. And the same, we collected organs, the same organs, so brain, kidneys, liver, and femur, and we were able to conclude the exact same conclusion. In all of those organs, lead is significantly reduced, including in the brain. Now, we do not know yet if this is because MTL2 crosses the BBB, binds to lead and take it out, or it's by an equilibrium shift. We suspect that it's the latter and not the former, but this is still under investigation. So with that, I would like to conclude our peptides peptides generally speaking, and more specifically our peptides can detoxify and excrete lead. That's a great and great news for the field as well as for revolutionizing chelation therapy. Our peptides can be administered orally, and this is very unique when it comes to peptides. And they are more active, they are selective, and they are. I haven't showed you results regarding toxicity, but clearly we have done a lot of work on toxicity. And based on preclinical evaluations, our peptides are significantly less toxic than the standards of care. Now, there's plenty of additional work that needs to be done. We would like to determine what happens in how is our peptide efficacious only in the case of chronic lead exposure? What happens when we administer the chelating agent for a long term? Can we get better efficacy? And what about the safety? And of course, we would like to see that these results can be translated into the clinic. Yes, and with that, I want to thank, there's plenty of people and bodies to thank, but for the time reasons, I will skip this, and I'm looking forward to your questions.
Thank you, Michal. I think that was a great overview and confirmed my hopes that we're moving forward in this particular area. Although I know there's a bump that you've already encountered that has nothing to do with the chemistry. Yeah. So there are a couple of questions. Let's see. One of them is one you've already addressed, I think, specific risks associated with using chelation therapy to treat elevated lead levels. And I'm not sure that was only for the agents that you're working on, but more general question. Then there was a question whether there were any clinical studies that you've done. And I think
Not yet.
Going to, yes. Unfortunately, it hasn't gotten to that point. Okay, this could have been my question. What's the timeline to envision the arrival of this product or products like this in the clinics?
So it's in the best case scenario, and we clearly do not face the best case scenario, not for technological reasons, but for other reasons, more economic reasons. In the best case scenario, I would estimate such program to require about 7 to 10 years until it reaches the clinic, until it reaches the market. Yeah, I would say 18 months until we start our clinical trials, and about 7 years to reach the market, to be available.
I think in terms of when you reach the clinical research stage, one of the people in the audience has volunteered to be a human for assessment of the drugs. Yeah. And then there was a question about a compound, an iron EDTA compound that was used. I remember this was a small study out of Morocco in
Yes.
kids. And it was the compound was put into biscuits. And there's always been a question with EDTA of how much you absorb it if you're giving it orally. And actually, one of the reasons why it's not used typically orally because of low absorption rate.
Mm-hmm.
So in that particular study, there was a relationship between pre-post blood levels. If you had any comment on that.
So generally speaking, the biggest limitation of EDTA, regardless of the route of administration, is its poor metal selectivity, and as a result, we have different types of formulations of EDTA. There's the tetrasodium, there's the disodium calcium EDTA, which is currently used. There's different types of, and also iron EDTA, and of course, iron EDTA can enhance. I assume that the reason why using such a salt is to enhance its oral absorption, but in reality, once it reaches the bloodstream, it is most likely interacting with many different other metals much before it will encounter a lead ion. Which eventually, again, brings us to the main conclusion that EDTA is not capable of distinguishing between the metal ion of interest, in this case lead, versus the higher concentration of other essential metals that we have. So in my view, yeah, EDTA is great, especially for low-income countries, because we produce tons of it every year for various medical uses. But the outcome, the medical outcome, in my view, is not as required.
I think I'd like to add to that. So EDTA, I think, was first developed as a preservative. And one of the mechanisms is that it binds calcium if you're not giving it as the calcium salt.
Mhm.
So like ferritin levels going up when we're sick to hide the iron from invading bacteria, I guess the rationale would be the same for the EDTA as a preservative. The deaths that I'm aware of in the US attributable to chelation therapy were with the use of sodium EDTA, not the calcium salt. And the hypothesis there is that giving a bolus of sodium EDTA, you end up swapping the sodium for calcium and precipitate a hypocalcemic cardiac arrest, which becomes very hard to reverse if you're not aware of what's happening. So we don't even stock, and haven't for decades, a
Mhm.
sodium salt of it, but always as a calcium salt if you're considering its use in chelation therapy for lead poisoning.
Mhm.
And my hope again is that the products that you're going to be working on when you ever get a chance to go back to lead and not other metals will be without having to have qualifiers like that. The toxicity profile will be minimal or none, if possible at all. Thank you. I
Thank
think
you.
that covers the questions and the concerns. For those that didn't get a chance to ask because of the time in the first couple of talks, I think I've got copies of all your statements and questions, and I will send them to the presenters so that they can address them for you, and we'll send your name and your email address if that's okay with you. If it's not, just to contact any of us from the lead program at Montefiore, and we can send them anonymously if you don't want to have your name sent to the presenters to get your questions answered. Nancy, for you for the end, I think.
That sounds good. And perhaps Ajara, our administrator, could put in the chat our contact information that was in the brochure, the phone number and the email address in case they want to send questions through us or have questions of us. And I would point out, I know several times people have asked if this has been recorded. The answer is yes, it's been recorded, and you all as attendees will be receiving that link as soon as it's ready. I would also want to note that the price of admission, if you will, is a very brief evaluation before you sign out of the meeting. We would very much appreciate it if you would all fill that out. It's very short and it's essential in our planning for next year. It's always been helpful, and those of you who've done that, I hope have seen over the years that we have paid close attention to what you have had to say. But with that said, we certainly want to give a huge round of thanks to our presenters today for their outstanding talks, as well as to the New York State Department of Health and our own staff who together have helped make this presentation possible. But most of all, we thank you, our attendees, for joining us. And hopefully together we're going to help create a future where lead poisoning no longer threatens the health and the potential of our children. So with that, unless you have any closing remarks, Maury, I would just to again thank everyone and wish you well. We'll see you next year.
I have nothing to add, or I shouldn't say nothing, but I have little to add to what you just said, Nancy. We're always delighted to be able to put this conference on every year, from its origins as a local conference in New York, downstate New York, to now reaching international levels, thanks to Zoom, but really thanks to COVID, which allowed us to think outside of our box, so to speak, our neighborhoods. And I think it's been very successful at disseminating a great deal of information about lead in its on many topics over the years. And thanks to Nancy, who's been its organizer every year for decades. And truly, truly appreciate all your efforts, Nancy. Thank you. Thanks to the speakers.